Rahim. Hello guys, and today our topic is hypokalemia. Hypokalemia means then that when the value of potassium inside the blood is less, the normal amount of potassium is about 3.5 to 5.2 milliequivalents per liter. Okay, it's milliequivalents per liter, and when the amount is less than 3.5, we can refer it to as hypokalemia. But there is a dangerous condition in which the death can occur. It results in mortality when the potassium level is less than 2.5 milliequivalents per liter, and it's a very dangerous decrease in the potassium levels. Why the death occurs? Due to the respiratory muscle paralysis, that is diaphragm. Okay, the muscle paralysis of the respiratory system result in the death of the patient. So what are the etiologies? First of all, the most important point, you need to understand that pH and the potassium are the have inverse relation. It means when the pH is less, the amount of potassium in the blood will more, and when the pH is more, the amount of potassium inside the blood will be less. Let's take an example of diabetic ketoacidosis. We are taking example of diabetic ketoacidosis, in which this occurs in diabetes mellitus type 1, in which there is a lot of ketone bodies inside the blood. So ultimately it's an acidotic condition, right? So pH of the patient will be less because hydrogen ions are more. It result in the solvent drag. Solvent drag means that water will move out of the cell. Solvent drag, okay? So water will move out of the cell, solvent drag. And this water does not move alone, it will carry potassium along with it, right? So the potassium will also move out of the cell. Potassium efflux will result. What does it mean? It means that the amount of potassium in the bloodstream will rise, and that's exactly what I'm saying, that when pH is low, the amount of potassium in the blood will rise, and vice versa. Let's take an example that if the pH is more than 7.5, it means that there is alkaline condition going on there, right? So the amount of potassium will be low in the blood. The amount of potassium will automatically be low. Or we can say that hyperkalemia means that hyperkalemic conditions. Hyperkalemia can also result in acidosis, right? We have seen that acidosis can result in hyperkalemia, right? Hyperkalemia can also result in acidosis. Let us see how it happens. First of all, hyperkalemia can be due to certain nephropathies like chronic kidney disease. Okay, it can be due to chronic kidney disease. It can be due to like renal failure, right? So there will be hyperkalemia component there. The kidneys are unable to secrete ammonia. It will affect the tubules to secrete ammonia. The secretion of ammonia will be affected. Secretion of ammonia will be affected. But here the point is that ammonia is not of importance. The important point is that the secretion of bicarbs. The secretion of not bicarbs but the protons will also be affected. It means that proton will start to build up inside the bloodstream, and hyperkalemic condition can result in acidosis. Secretion of proton will be affected, and this accumulation of proton in the blood is known as the acidosis. It's metabolic acidosis, right? So that's exactly what I'm trying to say here. Studies have shown that approximately potassium increases approximately by 0.7 milliequivalents per liter But how it will increase? Potassium will increase 0.7 milliequivalents per liter for every 0.1 drop in the pH. Because I have said that a decrease in pH will increase the potassium, so that's the relation we have. 0.7 will increase when 0.1 decrease in the pH will occur. Other causes for hypokalemia can be decreased intake. It's like very obvious cause. There will be decreased intake. The patient is not having enough amount of potassium in the diet. It will be decreased intake. First etiology. The second can be alkalosis, right? We have mentioned that rising when pH is rising, it will result in low potassium. And our topic for today is hypokalemia. Alkalosis can be result in the hypokalemia. The third is the sympathomimetic stimulation. I will write the whole word. It's worth writing. Sympathomimetic stimulation. What does it mean? It means that certain conditions in the body will stimulate our not central, but sympathetic nervous system, right? And what does it mean exactly? It means that there are thyrotoxic conditions. When there is hyperthyroidism, thyrotoxic conditions, and the condition we refer to as the thyrotoxic periodic paralysis, because thyroid hormones will stimulate the sympathetic nervous system, and this condition is known as the thyrotoxic periodic paralysis. And in case of thyrotoxic periodic paralysis, this condition causes the potassium to move inside the cells, and when potassium moves inside the cells, so extracellular amount of potassium will reduce, and that's we call as hypokalemia. it result it can be due to any underlying endocrine diseases, okay? And trauma can also cause potassium shift into the cell. We can also add trauma. Under the sympathomimetic stimulation, we can add thyrotoxic periodic paralysis as well as the trauma. So next etiology is the salbutamol toxicity. What is salbutamol? Salbutamol is beta 2 agonist salbutamol toxicity. If we give a controlled amount of salbutamol, it's used to treat asthma, right? And it's used to treat hyperkalemia, but our topic is hypokalemia. It means that when we give salbutamol in uncontrolled amount, it will cause hypokalemia. It will result in dangerous hypokalemia. We will study in hyperkalemia that in the treatment of hyperkalemia, we give salbutamol 4 times. We give the dose of salbutamol 4 times higher than in asthma, because salbutamol is beta 2 agonist, and beta 2 agonists are bronchodilators and vasorelaxants, right? So salbutamol is also used in asthma, it is also used in hyperkalemia, but its toxicity is dangerous. It can lead to hypokalemia. The next condition, it's also very logical. There is the renal losses of potassium. And in the renal losses of potassium, one important aspect come, that is increased amount of aldosterone. And what is the primary function of aldosterone? Aldosterone is a hormone produced by the adrenal cortex. Its function is to reabsorb sodium along with water. But there is a price we have to pay. It will result in hydrogen and potassium excretion. It means when the conditions of the hyperaldosteronism will come, there will obvious amount of hypokalemia occurring inside the body. So, what are the conditions that result in hyperaldosteronism? They can be primary conditions or they can be secondary conditions. First of all is the Cone syndrome. Cone syndrome is also known as primary hyperaldosteronism, in which there will a huge amount of aldosterone inside the body. It can be due to adrenal cortex tumors, right? So amount of aldosterone will increase and subsequently the potassium amount will be less. The second is the bilateral adrenal hyperplasia. Bilateral adrenal hyperplasia. Note down that it's bilateral, it's not congenital. Adrenal hyperplasia, let me write first, hyperplasia. In case of bilateral adrenal hyperplasia, there will be increased amount of aldosterone. But in case of congenital, it's very opposite scenario. It will result in the decreased amount of aldosterone. But we are concerned with the bilateral adrenal hyperplasia. The next thing is that conditions like heart failure, it can be congestive heart failure, right? It can be massive ascites. But why these conditions are resulting in hyperaldosteronism? Because these conditions will result in low renal perfusion. Low renal perfusion means low GFR, and low GFR will trigger the renin, increase the renin angiotensin aldosterone system, and this RAS will activate the aldosterone to be released. These are secondary hyperaldosteronism conditions. The next is the congenital tubulopathies like Bartter syndrome and the Gitelman syndrome. Bartter syndrome and the Gitelman syndrome, in which there is a gain of the function of sodium chloride, either or it can be gain of the function of the sodium potassium 2 chloride cotransporter in the ascending limb or in the distal tubule of the nephrons. I have made a separate video on Bartter and Gitelman syndrome. Subsequently, this Bartter and Gitelman syndrome will going to activate RAS, right? Because there is a huge amount of polyuria, there will be hypovolemia inside the body, so ROS automatically be activated. Talking about the congenital tubulopathies, there are salt losing nephropathies as well. There are salt losing nephropathies, and in case of salt losing nephropathy, sodium will be loose inside the urine, and it will activate the RAS system. After that, there are renal tubular acidosis. Renal tubular acidosis, more specifically 1 and 2. 4 is not included in case of hypokalemia. And the next is the GI conditions like vomiting and diarrhea, because in case of vomiting and diarrhea, there will be loss of fluid along with the electrolytes, right? Including the potassium. So these are some etiologies for the hypokalemia. Let's talk about the clinical features of hypokalemia. In case of the clinical features of hypokalemia can be like muscle cramps and muscle weakness. There can be muscle cramps as well as the weakness of the muscles, because potassium is involved in case of muscle contraction and relaxation, right? And the second is the ileus. What is ileus? Ileus means that there will be lack of peristalsis, because peristalsis are ultimately due to the muscle contractions. Peristalsis will be inhibited or it will be reduced. And the feature of ileus is that there will be absence of the vowel sound. Absent vowel sounds. Because physiologically there are approximately 3 vowel sounds per minute we can hear in the right iliac fossa. Okay, there are physiologically 3 vowel sounds heard in the right iliac fossa, but in case of hypokalemia, there will be loss of peristalsis and there will be absent vowel sounds. The next clinical feature is areflexia, the loss of reflexes in the body. For example, deep tendon reflexes. These reflexes will be diminished. The second is the flaccid paralysis will be inside the body. Flaccid paralysis. Because ultimately the muscles are not functioning, so it results in flaccid paralysis. The next is the carbon dioxide retention, which is known as the carbon dioxide narcosis. Because diaphragm is not working, because diaphragm is also a muscle ultimately, so it is not working and it result in the diaphragmatic paralysis. It result in the carbon dioxide retention in the bloodstream, which is known as the carbon dioxide narcosis. And the last but not the least is asterixis. Asterixis is known as the flapping tremors in the layman like language. It's asterixis. It's a very important diagnostic criteria to understand whether the hypokalemia is in the patient or not. So what are the investigations that we can put forward in case of hypokalemia? Investigations, so first of all is very logical, we should check the serum potassium, right? Serum potassium must be considered. The second is a very important test known as the transtubular potassium gradient. I will not write the whole term, but it's transtubular potassium gradient. And what exactly does it mean? Transtubular potassium gradient is a test used to estimate the amount of the excreted or amount of reabsorbed potassium by the renal tubules. Basically, this test is used to estimate the function of the tubules in secreting or reabsorbing the potassium. But if its value is more than 4, it means that potassium is being secreted more, and that's exactly hypokalemia. Why hypokalemia occurs? Because the transtubular potassium gradient value is more than 4. It means that there will be renal potassium wasting. There will be renal potassium wasting. The next condition the next condition is very important. It's ECG, electrocardiography, and ECG is very important in understanding why potassium is high or low, because potassium is involved in repolarization. The importance of potassium is in repolarization is holds a very specific place, because in our ECG line the T wave is for the repolarization, and when there is absent or low or inverted T wave, we can immediately identify that there is some kind of hypokalemia occurring inside the body. First of all, the first finding in the ECG will be the T wave will be less. It can be absent, okay, in case of severe conditions, or it can be inverted, right? Because repolarization is not being occurring, but inverted T wave is also present in case of two other conditions which are known as unstable angina. Unstable angina, it can be in hypokalemia angina, it can be in hypokalemia, that what we are discussing now, and it can be in non ST elevation MI. So we have understood that inverted T wave can be in unstable angina, it can be in hypokalemia, it can be non-ST elevation myocardial infarction. So we have to rule out other conditions in order to fully understood that this inverted T wave is only due to hypokalemia, right? The next finding in ECG is the ST segment depression. ST segment depression will be there, right? And the third finding of ECG will be P wave will be peaked. P peaked wave, right? There will be P peaked wave. And this is known as the pseudo P pulmonale. Pseudo P pulmonale. I will show you that P pulmonale is happening in another condition. We will discuss that. Because if the P wave is more than 2.5 millimeter in limb leads, right? If the height of P wave is more than 2.5 millimeters in limb lead, in the absence of pulmonary artery hypertension, in absence of pulmonary artery hypertension, then we can say that this peaked P wave is due to hypokalemia. Otherwise, the hypokalemia or the peaked P waves can be also a diagnostic criteria for pulmonary artery hypertension, and that is known as the P pulmonale. That's why we are saying that it's pseudo P pulmonale. Although the P wave is peaked, but it's not the condition for the pulmonary artery hypertension, right? The next finding in the ECG will be PR interval. PR interval will be prolonged. PR interval will be prolonged, right? Prolonged. The next is the prominent U waves. There will be prominent U waves in case of hypokalemia. Prominent U waves will be seen, and there will be elongated QU interval. Although in normal conditions we say QT interval, but I have said that T wave can be absent in case of hypokalemia, so we just directly say that QU interval will be prolonged because T wave is absent, right? So in conditions of hypokalemia, we can have the ECG like the normal ECG is P, then is QRS, and then is the T wave, right? It's the normal ECG we can see. But in case of hypokalemia, the P wave will be peaked. There is a peaked P wave. Okay, there is absence of T wave, there will be prominent U wave, or the T wave can be inverted. There will be ST segment depression. Okay, the ST segment will be depressed, and QU interval will be prolonged. These are some conditions you can just integrate in case of ECG. So, what are the treatment aspects? Treatment aspects for hypokalemia. Let's discuss about it. I can just write RX in case of treatment. What are the treatments for hypokalemia? First of all, one more important thing that this hypokalemia can trigger ventricular arrhythmias known as the torsades, torsades de pointes, and it's a very deadly kind of hyper like um, ventricular arrhythmia because it results in sudden death of the patient. Torsades de pointes, but not only hypokalemia, but hypomagnesemia can also result in same kind of ventricular arrhythmias, right? So let's talk about the treatment aspects. First of all, in case of potassium between the range of 3 to 3.5, although it's normal, but 3.5 is normal, not 3. So we can just give oral potassium chloride. We can give potassium chloride orally, right? We can give oral supply of potassium chloride, or we can give pot chlor. Pot chlor is also potassium chloride that is given orally. But if the potassium is less than 3, if potassium is less than 3, or the patient cannot have oral supplements of the potassium, then we can give IV infusion in case of potassium less than 3. So the IV correction can be given and of the potassium chloride. So first of all, there will be IV correction given in the patient of potassium chloride, and this potassium chloride is very important for the patient to have their potassium back to 3. We just want to correct the potassium until 3, and then we can shift the patient to have oral supplements. We are not correcting potassium from, for example, 2.2 to 4 or 2.2 to 5. We are just trying to make the person comfortable from 2.2 to 3, and then we will disconnect the IV line, and then we will just ask the patient to have oral amount of potassium chloride, and this potassium chloride in case of IV should be given slowly in form of infusion. Last is the mathematical thing, you can say that it's 1 milli equivalent rise in the potassium, rise in the potassium, we should give 200 milliequivalents of potassium chloride, milliequivalents of potassium chloride per 24 hours, because this amount of potassium chloride not should be given abruptly or immediately, because it result in dangerous amount of hyperkalemia, and again there can be ventricular arrhythmias, the heart may stop. So this amount of potassium chloride must be given IV over a very long amount of time, that is 1 day, 24 hours, it can be 48 hours also. Last is the like a numerical question, that for example if a patient is on amphotericin B, amphotericin B is also very notorious to cause the potassium shift into the cell. So amphotericin B, if a person has amphotericin B toxicity, and when we have checked the electrolyte like panel, we have found that potassium is approximately 2.3 milliequivalents per liter. So what is the amount of potassium that we are trying to correct? We are just trying to correct up till 3, and then we can disconnect the IV. So the amount of potassium we are trying to correct is 0.7 milliequivalents. Let's talk some bit about mathematics, that 1 milliequivalents rise in the potassium will require 200 milliequivalents of potassium chloride. But if the amount of potassium rise we need is 0.7, so how much amount of potassium chloride should be needed? Just cross multiplication. The answer is 140 milliequivalents of potassium chloride over 24 hours should be given in order to rise from 2.3 to 3, and after that we can just disconnect the IV infusion, and we can give the patient pot chlor or oral potassium chloride. The last thing I need to mention, that if the amount of potassium that need to be given is more than 20 milliequivalents, we will prefer the central line. Okay, and if the amount of potassium that is needed to be given is more than 40, then we are preferred to give IV, that is peripheral line, right? This was just some extra edge. So this was for today. I will see in the next video with talking about hyperkalemia and its etiology, the diagnosis and the treatment. And till then, goodbye.